Hello, my name is Katherine Woods, student ID 3028536, and this is my AVMA task video for VTHT 1341 Anesthesia and Surgery Assisting. So when admitting a patient for a surgical procedure, it's important to keep a physical copy of an admission form. An admission form is primarily used to help the doctor and staff easily identify a particular patient. And so this form will have the patient's first and last name and their signalment. So species, breed, age, sex, and then it's important that the admission form also tells of any pertinent medical information, so any prior known diseases, any possible medication reactions. The admission form also should have the name of the owner, first and last name, contact information, and then our admission form also has a line to keep track of the weight and the temperature for when the doctor goes in and does the preoperative exam and does a TPR. We can also have a space to write down any abnormalities found in the preoperative exam. They also have a list of all of the patient's reminders, so things that are coming due just in case we need to get some of those done while they're in the hospital. The admission form is then to be put on top of the patient's chart for ease of identification throughout the day. It's important to keep any pertinent information on a patient or treatments or procedures done recorded in an electronic medical record. The electronic medical record's purpose is twofold. It serves as a record of the patient's sensitivities to drugs, their overall medical condition, and any treatments or procedures that have been performed on them, both for the use of our clinic or another clinic that would need to know the history of a patient. It's also technically the hospital's property, and so if there was any legal ramifications of something, the electronic medical record serves as a means by which a hospital can show that everything was properly recorded and to avoid any unwarranted legal repercussions. Electronic medical record. This is for Mr. Gus Valentine. He's a little Frenchie who just had a dental today. So this morning when he was admitted, this pink line here is our surgical soap. So we can go ahead and pull this up. All right. So this is an example of our patient's permanent medical records. Ours are all electronic. The line in pink is a dental or surgical soap. And if I click into it, it opens it up. I can go back to the history. Anything in red is medication or an RX label that got sent home. We have the dental discharge instructions in blue. Different forms are linked under this turquoise color. So like our canine dental page today, so it shows all of the teeth, any that were removed, any that were missing. And we can filter things in the top, so I can push the surgery button and it brings up the surgery for today. I can push the regular soap button. It brings up all of his information from previous exams. I can pull up his labs, see different labs that he had. This is his preoperative blood work right here. And then if he had any previous medical records, I could go and we usually just scan them in and link them. So it says right here, previous medical history from Leanne Animal Clinic. So I can click on that, hit display. It pulls up all of his previous records as well. Why it's important to keep track of consent forms, because our patients can't communicate for themselves, and the clients are the legal owner of that animal, and so they need to give us consent in order to perform anything on an animal prior to doing any surgical procedures. When the owner first comes in to drop the patient off, we need to make sure they sign the proper consent form. So this is an example of our dentistry consent form. We have the owner's name, the patient's name, contact numbers, contact email. They can authorize any fees that they think are necessary, or they can authorize up to a set amount. So we kind of know if something goes wrong, if we need to add on other diagnostics, what the owner has approved in the case where we can't get a hold of them by one of these two phone numbers. And so then we need to make sure that this is signed and dated. Along with the consent form, we also give them a cost estimate. So this has a breakdown by line item, and then we give a low and high cost range, and then we have the owners okay everything and sign it. So as we're going over the consent form and the estimate for everything, we want to make sure that the owner knows what's happening during the surgery. So for Gus getting a dental, he was a dental level 2, which means that we don't expect there to be any teeth needing to be extracted. So I would, explain to the owner, we're going to go ahead, we anesthetize him, we intubate him, make sure that he has an open airway. We monitor his blood oxygen levels, his respiratory rate, his heart rate, his ECG, internal temperature, and blood pressure are all constantly monitored by a technician and an assistant, and the doctor is overseeing everything the entire time. We go ahead and chip off the tartar, take x-rays, polish the teeth, and then based on what we see from the dental x-rays, if we see any teeth that need to be extracted, we call the owner and get permission over the phone. Beforehand, we issue them a new cost estimate, get consent over the phone before we proceed with any extractions. Today, Gus did end up needing 3 teeth removed. So we had to call the owner, let them know, because he is a brachycephalic breed, sometimes these dogs with smaller, more cramped mouths need some unforeseen teeth extracted, and the owner consented, so he did have some teeth pulled today. These are what we call cage cards. So we have, his information up at the top. His name is Gus. It has his ID, his last name, and all of his signalment. So it has his species, his breed, his coat color, sex, things like that. When we go ahead to put the patient into the back, we want to make sure we keep the cage card with all the signalment information with the patient, put them in a kennel in the back, and then immediately clip this onto the kennel so that everybody walking by knows that the brindle Frenchie in this kennel is Gus. So that's how we know that the correct patient is getting the correct procedure done to them. It also has, what procedure is written, so he would have a D2, in the doctor that he's with, so we know where he is at all times. We always make sure that we have blood work, pre-anesthetic blood work done within 3 months leading up to a procedure. So I'll zoom in so you can see this a little better. So this is Gus's surgery. I'm going to go back to the history and also filter it because of the magic of electronic medical records. So just done January 10th, we did a preoperative screen with a chem screen. And so you can pull it up and see his blood, last blood panel. It has anything highlighted in red that's in an abnormal range. He needed any other labs done, we have little in-house laboratory forms. The technician knows, what the results were, and we can track that for him throughout the day. It's also in the medical record. I can click labs and pull it up, and it'll have its own little line item up here under his lab, so I could click into that and I could see the same results that are on the paper form. So that at the end of the day, when these get recycled, we still have the permanent electronic medical record with all of the information that we need. One of our most important sheets, while Mr. Gus is in for his dental, is his anesthesia form. So this has, again, all of his information. It has the same information that was on his cage card, name, first name, last name, ID, all of his signalment, and his birthday. This has his weight, and we also converted it to kilograms. Has the date, any procedures to be done, if we want any additional treatments, the doctor and the technician that's in charge of him, and then this was his anesthesia plan for the day. So he had butorphanol and midazolam, and then he also had some Serenia, and so it says, the strength, the milligrams, the volume, where it was given, what time it was given. We have pre-anesthetic medications, induction drugs, so he got some propofol at 12:17. If we give any other intraoperative medications, if we needed to do regional nerve block, we would put that in here too. We say IV catheter size, the location that it was given, the type of fluids, the rate of fluids, the endotracheal tube size, and the reservoir bag size. So we keep notes of all of those, and then in the future, if he comes back and we're trying to figure out what size E-tube that would fit him, we can look back and see what was previously used. We have the time that the anesthesia begins and ends, and the procedure itself begins and ends. We have total fluids given, what time the patient was extubated, temp, post-op, And then during recovery, if there was a fluid bolus, we have the plan down here. If there's any laser therapy, we have notes on the induction maintenance and recovery. If there's anything abnormal, we keep notes there. We always do a complimentary toenail trim and anal gland expression, so we mark those off as we go. And then any post-op medications. Since he did have some non-complicated extractions, we went ahead and gave him some Rimadyl to go home. So, technician, before we bring the patient back into the room, we sit the owner down in the exam room and we go over. We have take-home instructions, discharge instructions. So you can see it says surgery, anesthesia, and it goes over all of the different instructions. We always tell them for our dentals that you can come in for a courtesy dental recheck, especially if he's getting extractions. We say in 10 to 14 days, and we list the range here. And we want to assess the healing of the extraction sites. Oral sutures will dissolve when gum tissue is healed, so if he didn't have any extractions, we could take that part out. Clients, if it was just a simple D1 or D2 and we were just polishing up the teeth, there shouldn't be need for a dental recheck, but if the owner ever has any questions or concerns, they're welcome to call us. The courtesy dental recheck is with a licensed veterinary technician, so we have them schedule that appointment. We always recommend, whether there are extractions or not, that we feed canned or softened dry food, just to make sure, the first night when they come home, their gums might be a little sensitive, and especially if teeth have been extracted, we don't want them to be chewing on any hard food that could cause dehiscence or pain in the area. So we say feed that softened food, and if there are extractions, we say do it until the dental recheck. Do not allow access to any toys, hard treats, or chews until after the recheck, and then they can restart home dental care after that recheck appointment in 10 to 14 days if the veterinary technician says that they looked healed enough. The pet would have been given a half-size portion of meal at a hospital, so we say offer a half-size portion meal once home. If after an hour Gus is keeping food down and not showing signs of nausea, or offer another half portion. If Gus experiences post-meal nausea or vomiting, offer a small amount of water, but withhold food until the next morning. And if he shows disinterest in food for longer than 24 hours, to give us a call. So here we mention, different means of care for Gus, and we reiterate if anything seems abnormal or if he seems painful, then to call us right away. We mentioned that he was on IV fluids during his dental procedure, so to take him out for extra potty breaks is needed overnight. And then we warn them that blood-tinged saliva is considered normal for the first few days following oral surgery, but if there's hemorrhaging blood, that's cause for concern and that's not normal, and please notify us right away and bring him in. And please also call to schedule a recheck if this is the case. We mentioned the medication that he was sent home with, so he had some Rimadyl injected, so he had some pain medication on board for 24 hours, but we sent him home with some Novox to give tomorrow night, which is just the same, it's the oral tablet of the Rimadyl, so he can start that next dose, and we say that that's due tomorrow night, and to continue as directed until gone. The other medication we sent home was deoxychlorohexidine mousse to help with that nasal fold infection that we found. And then call us if there's no improvement or if it worsens at any point, and then we can discuss further workup or, a cytopoint injection, so further medications that we can use. And then we always include behavioral responses for pain in either the dog or the cat. So since he was a dog, we mentioned different signs of vocalization, facial expressions, body posture, self-awareness, activity level, attitude, appetite, urinary and bowel habits, grooming, and response to touch, and anything in there that's considered abnormal or painful behavior. So we go through that entire talk. So during the discharge, we want to be talking about possible complications or things that the owner should be looking at. We give them the discharge instructions and at-home dental care instructions. So they get sent home with all of those things, and then we have a callback set for the next day so that one of our veterinary technicians or veterinary assistants calls just to make sure the patient is recovering from anesthesia properly. And then we always urge clients, if they have any questions, any concerns, give us a call. And we also offer them local 24-hour emergency clinic contact information with any medications that are going home. So with that Novox, I would want to let them know, discontinue this medication if you see any vomiting, diarrhea, or black tarry stool. That can be a sign of internal hemorrhaging or gastrointestinal upset, which we know that some carprofen and other NSAIDs can cause. So to discontinue the medication if they see any of those and give us a call, we would want to stop that medication and then maybe attempt something else to keep some pain, pain relief and analgesia on board. For dental extractions, we want to make sure that those sutures are staying intact, that they're not getting too much food in there, the owners don't notice any infection, there's not hemorrhaging blood from the mouth, that the patient's energy and appetite come back to normal. If the sutures were to get torn out a little early, we want them to give us a call right away. They can come back in, we can kind of assess the tooth and possibly resuture that with sedation if necessary, or send them to a 24-hour emergency hospital. And with a brachycephalic breed like Gus, we were constantly monitoring his respiration all day, making sure that he was pre-oxygenated and that he had extra oxygen when he was recovering. So we let the owner know, definitely monitor him for any signs of respiratory distress. If it seems like he got, any regurgitation or any saliva or anything kind of stuck down in his throat that could complicate his airway, that's definitely a medical emergency, and they need to give us a call or head to an emergency facility right away. Alright, so I'm going to show how to strain for the various types of blood draws. This is my friend Squiscar. So, in order to do a canine jugular draw, can you sit? You have the patient sit. If it's a large dog, you can put them up against a wall or into a corner. For a small dog like this, you can have the restrainer come from behind, and they just kind of hold the mouth, good dog Squiscar, and hold up. And then the person coming in for the jugular draw has a nice view right here. They can occlude the vessel at the thoracic inlet, and then the jugular vein will be right along the line of the throat right here. It's a good dog Squiscar. If we're doing a cephalic blood draw, I'm going to make sure I have good hold of the head, over to the side, I know, good dog, and then I'm going to take the leg, I'm going to reach around, roll the vein to the side, and then push the leg forward, so I'm occluding the vessel, rolling the vein onto the top of the leg, and my fingers are pressed behind that elbow, so if he wanted to pull his leg back suddenly, he couldn't. Yeah, I let you that time, huh? And to do a lateral saphenous vein, it goes on the lateral edge of this leg, so I would make sure I have a good hold of the patient up front, and I would hug in the back too. Hopefully we would have a second person to come around and occlude the vessel for us, or the person drawing blood could use a tourniquet, and then the person doing the venipuncture would just come in right here with the needle. We could also hold him in lateral if we really needed to, and if at any point he seemed like he would be uncomfortable with venipuncture, we would go ahead and apply a muzzle or an e-collar. In order to safely take a large canine patient out of a kennel, we're going to go ahead and prep a slip lead. So I'm going to go ahead and make sure it's open nice and wide. I'm going to hold it in my hands. I'm going to hold it down at the level that the dog's head will be when she comes out of the kennel, and then I can open the door, stand to the side of the door, let the patient walk out and slip the slip lead around her head. Good girl, Maple. And then in order to put the dog back in the kennel, I let her walk in. I kind of grab the slip lead from around the back of their head as they're walking in. That way their head is away from me. They're used to people usually petting them around the scruff of the neck. So I just kind of grab it in one fluid motion and let it pull itself off as the dog goes back into the kennel. When you're opening the kennel door, you don't want to block the entrance with your body because they might take that as an aggressive act. So when I took her out of the kennel, I stood to the side so that she could see that I'm not aggressive. And then I just held the slip lead out for her and she walked right in. Always keep it safe when taking a dog out of and putting her back into the kennel. To apply a standard basket muzzle, you need to make sure that it's long enough to reach the tip of their nose and give them a little bit of space. You can, if they're seeming non-aggressive, you can just kind of come up from the side and place it on them, and then make sure it's nice and sized and snapped. If he were, a little more nervous, kind of shifting around, I could come from up top and flip the muzzle over the nose. And again, if they were aggressive, I would have someone wrap a towel around their head, stabilize them, and then place the muzzle. In order to properly place an e-collar on a patient, so this one has already been all snapped together. If it's a cooperative patient who hasn't shown any aggression, you can just make sure you bend the little folds out of the way. Just make sure you don't hit their eyes, I know, bud, and pop it over their head. So this looks like a good fit for him. This will be around where his collar would normally reach, and his nose is about an inch or two inside the cone. I have some non-stretch gauze here. You can see it doesn't have any give, and I've wrapped it around twice so that it's nice and strong. So we just loop those around the little edges of the e-collar. I like to flip it around so that the bow's on top, so it's more difficult for them to scratch at it and possibly untie the bow. I want to make sure it's nice and secure so that they can't get the e-collar off, but not so tight that you can't fit a finger underneath there. Some owners will, think that that's a little too tight for the patient. You just need to reassure them it needs to be tight enough that they can't pull it up over their head. In order to perform a proper pre-operative examination, the main things we need to get are temperature, pulse, and respiration to check his primary vital signs. So this is Zico. He's going to be getting a dental cleaning today. His mucous membranes are nice and pink and moist, and he has a capillary refill time of less than 2 seconds, so he seems adequately hydrated and he has good perfusion of his blood vessels. There's no nasal or ocular discharge, no coughing or sneezing, he hasn't vomited or had any diarrhea in the last few days. So now I just need to make sure that his heart sounds good and his lungs sound good, so I'm going to use a stethoscope. I'm going to go just past the axillary region on the thorax. Good boy, and I hear a nice even heartbeat. So I'm going to go ahead and count the beats in 15 seconds. Okay, so that was about 27. So since we took that over the course of 15 seconds, we're going to multiply that by 4. That's about 108, which is pretty normal for a nervous dog. Normally a good heart rate range is 60 to 180 for a dog in the hospital. That's still within the normal range. So now I'm going to do the same thing, but a little bit higher. I'm going to listen for his lung sounds, and I'm going to count how many breaths he takes in a 15-second time frame. Okay, so I counted about 7. We're going to multiply that by 4. So that's about 28, and a normal range for a dog that's not anesthetized is going to be somewhere between 10 and 30. So that's at the high end of the normal. So now the only thing we need to do is take his temperature. I have a thermal rectal probe here. Okay, and then gently insert it into the rectum. Good boy. And unfortunately, we don't have any thermometers that can take an accurate reading in the ear cavity or in the mouth. And that wouldn't be practical because a lot of patients will bite down on it. So 100.8 degrees, that's nice and normal. Anywhere from 99.5 to 102.5 is considered a normal range. So overall, his lungs sound good, his heart sounds good, his temperature is normal, he's within all the normal ranges. And he's just getting a routine dental cleaning. I believe this patient's only about 4 years old. He doesn't have any pre-existing health conditions, so he's going to have an ASA grade of 1. Minimal anesthetic risk, no previous known medical condition. Performing a preoperative exam on a cat is very similar to performing one on a dog. They just have some different parameters. So first I'm going to sculpt the heart and the lungs. I place the stethoscope just over the heart, so the ventrolateral aspect of the thorax. And I can hear the heart, so now I'm going to count the beats for 15 seconds starting now. All right. So at about 55 in there. So a normal heart rate for a cat's going to be between 150 and 220. That's going to be right around 220 for little Boo. She's a little bit nervous probably. Sometimes if patients have been dropped off for their preoperative exams, their heart rates can be a little fast. Just because they're nervous, you're hiding it well though, huh, Munchkin? I'm also going to go ahead and sculpt her lungs. Make sure I don't hear any cracks or wheezes or popping. So I'm going to try to listen to all 4 lung fields on the right and the left. That sounds nice and normal. Okay, so those breath sounds are nice and normal. Good. And I'll count how many times she breathes in and out in a 15-second period. All right, so I got about 20 breaths. And the normal for a cat is 16 to 40 breaths per minute. So that should be normal for her. So this is a rectal probe. I already have some lubricant on the end. We're going to go ahead and obtain a rectal temperature. Good kitty. So 99.5 is her internal temperature. Anywhere from 99.5 to 102.5 is normal internal temperature for felines and canine patients, so that's nice and normal. Doesn't have any blaring issues upon her preoperative exam. She's not ataxic. She has a good heart rate and breathing rate, good temperature. All in all, she's a good candidate for her dental procedure that she'll be getting. The only thing is she is a known diabetic, so instead of a normal ASA score of 1, I'm going to go ahead and give her a 3, just because having diabetes will make her anesthesia a little more complicated. She's going to handle the anesthetic drugs differently. We're going to need to look and form a different anesthetic plan than we would with a patient who didn't have diabetes. And we're going to have to monitor her stats more carefully, make sure she's well hydrated, and be prepared for any complications that arise during her dental. Now I'm going to do a blood draw on a cephalic vein of a canine patient. This is Mr. Otis. So again, I have an assistant holding off the cephalic vein. So this runs along the rostral aspect of the leg. So while we occlude the vein, he's also rolling it over to the side so it kind of lines it up more on top of the leg. I'm going to wet down the fur with isopropyl alcohol. This also sanitizes it before I perform venipuncture. And then we're going to go ahead and use a clean needle and syringe. Alright. And make sure that the seal is kind of broken on that syringe. So I'm going to visualize this vein here. I'm kind of stabilizing it on the side with my thumb. And then I'm going to take the syringe with the needle has the bevel side pointed up. I'm going to insert it into the skin. And then pull back on the syringe until I see a flash of blood in that hub. And if I'm not sure where the vein is, I can kind of palpate it higher up on the leg. Here we go. So we see a little flash of blood. I'm going to pull back on my syringe. And then before I pull the needle back out, I'm going to put my thumb over where we punctured that vein. And then we're going to hold that off. Make sure no hematoma forms. Hold it off for a good 30 seconds. And then you can see the blood that we've just drawn from his cephalic vein. Now I'll do a blood draw on a cephalic vein of a feline patient. This is Miss Muffy again. So my assistant is holding off the vein at the same time that he's rolling it to the side so that I have more access. I'm holding on to the front of the paw in case she were to try to pull it back. I take the needle with the bevel side up, gently insert it under the skin, and then pull back on the syringe until I see a flash. And when I'm done, I go ahead and hold off before I pull out, and then my assistant takes over so that we keep hemostasis and avoid clot or hematoma formation, and you can see the blood that we drew from there. I'm going to demonstrate how to do a jugular blood draw on a canine patient. This is Miss Matilda. We're going to be doing a full senior blood panel today. So I have a helper holding her up against the wall, or in this case we have a little corner that we like to go to. And then I'm going to go ahead and press right. I'm going to occlude the vessel just by pressing right in the thoracic inlet, and I can feel around for the jugular vein. Once I feel confident that I can kind of feel the vein, it feels a little bit bouncier than the normal area. If I were unsure if that were the vein, I could stop occluding and occlude again. I can kind of feel that vein fill up with blood again. So now I'm going to wet the area with some isopropyl alcohol, cleanse it thoroughly. Make sure we let it dry just a little bit. And then I'm going to take my needle, uncap it, make sure that the seal is broken on the syringe, and then I'm going to take the needle with the bevel side toward me. Gently insert it.
David, here, or Nancy's here with the two boys.
Flash, and then I draw back on the
Make
syringe.
sure you go safe.
And as I draw back on the syringe, I'm making sure that the needle doesn't push any further in, and you're moving your arm. So I'm going to go ahead and hold off that vein before I pull the needle out to make sure we maintain hemostasis and avoid any hematoma formation. And then I can process my sample. Alright, so I'm going to do a jugular blood draw on a feline patient. I have an assistant holding her head up and holding her legs down for me in a sternal position. I'm going to head and occlude the vessel right here, and I can see it pop up. So I'm just going to wet it with some isopropyl alcohol. And then I take my syringe, make sure the seal is broken and the beveled end of the needle is up. I'm going to insert it under the skin. And I see a flash of blood, so I'm going to pull back on the plunger of the syringe and hold it steady until I get the proper amount of blood, and then I'll hold off the needle as I pull it out. And then my assistant's going to take over holding off that vein to maintain hemostasis and prevent formation of a hematoma. And then we can go ahead and process our blood sample. So to do a blood draw on a lateral saphenous vein of a dog, I have my assistant holding off the back of the leg, which is making this vein pop up. You can see it running right along here. That's the lateral saphenous, as opposed to the feline patients we use medial saphenous veins. So I have a sterile needle and syringe. I'm going to use some isopropyl alcohol to wet the area and clean it. Let that dry for a second or two. And I want to make sure I select a syringe for the proper amount of blood that I'm drawing. This is just a demonstration, so I'm just going to get a few drops of blood. So with that vein being occluded so that I can see it, I'm going to stabilize it with my thumb on one side, take my syringe, and the needle has the bevel side up for easier entry into the skin. And I'm going to push into the skin, puncture the vein, and then draw back on my syringe until I see blood. And then before I pull out, I'm going to go ahead and put my finger on there. Then we're going to hold off that vein for at least 30 seconds to maintain hemostasis, make sure we don't have any hematomas forming in there. Then you can see the blood that we just drew. I'm going to show how to perform a medial saphenous blood draw on a feline patient. I have a helper who's holding the top foot up for me, and he's also pushing off and occluding the vessel. So this is the medial saphenous vein, and I can see it right here. So I'm going to go ahead and put my thumb right next to the vein so that it stabilizes it. I'm going to take my syringe with the bevel of the needle pointed up, insert it under the skin, and then into the vein, draw back, and then I'm going to go ahead and hold off pressure when I pull out of the vein to maintain hemostasis. And you can see the blood in here, so we were able to do a blood draw. Before we formulate a pre-anesthetic protocol on Mr. Ronald, he already had some preoperative blood, so we need to make sure we have minimum databases prepared for each patient. Each patient prior to anesthesia, we need to make sure they have a healthy packed cell volume or hematocrit. We also do a total protein or total solid. We also check his blood glucose levels, make sure that that's normal because that'll directly affect his body systems, especially while he's under anesthesia. We also double check the BUN, the blood urea nitrogen levels, to make sure that his kidney or his liver is able to properly filter the nitrogen out of his blood. And we also check his ALT. That's another good indicator of liver health. If we saw an elevation of BUN or ALT, we would know that something is wrong with the liver. And anesthetic gases are usually filtered by the liver and the kidneys, so we want to make sure that those are functioning properly before performing anesthesia. All patients that get screened here, we check not only for the minimum databases, but we also double check them for creatinine, their creatinine ratio, their ALP. We do a full, complete blood count. If the patient were sick in any other way or had another medical complication, if it was a diabetic, we would need to make sure we monitor their blood glucose, probably also run a full urinalysis before the procedure. The doctors might want additional blood tests run as well. If the dog had Cushing's, we would have made sure to run a dexamethasone suppression test or ACTH test beforehand to make sure everything is functioning properly. If the dog was getting operated on with a broken leg, we would need to make sure we take x-rays, lateral views and AP views, probably take x-rays of the associated structures as well, just to figure out where the break is or if it's a soft muscle strain. For a dog getting a cystotomy, we would definitely need to make sure we had ultrasounded the bladder, run a full urinalysis, probably run a few other urine tests as well. A lot of the doctors here like to take a lateral radiograph beforehand to see the stones, and then one post-operatively to make sure there are no stones visible in the bladder. So depending on what the patient, is coming in for, they might have a range of different laboratory tests run on them beforehand for a preoperative screening. So we formulated a pre-anesthetic protocol for Mr. Ronald. He's a 9-month-old golden retriever who's getting neutered today. I'm going to be assisting in his neuter later today. Me and Dr. Weil discussed it, and we decided that a good protocol for Ronald, since he's a young, healthy canine, we're going to start off with some butorphanol, 10 milligrams per milliliter at 0.2 mg per kg, because butorphanol is an opioid, so that's going to give him some analgesic properties, and it's also a bit of a sedative. We're also going to go ahead and mix that with some midazolam at 5 milligrams per milliliter, so 0.1 mg per kg, because that is a benzodiazepine. That'll give him some sedation, so extra sedation and a little bit of muscle relaxer. The only thing is the midazolam, since it is a benzodiazepine, it can cause some salivation and some gastric issues in canines. So we're also going to go ahead and after induction, we're going to give him some Serenia IV at 1 mg per kg, just to kind of combat the nausea, prevent any regurgitation while he's under anesthesia. So between the butorphanol and the midazolam, he's going to have really good sedation. He'll have some pain control on board before he even has his IV catheter placed, and then he'll have some muscle relaxation, which will be good since he's going to be neutered today. And then we're also going to send him home with some post-operative pain medication, and the doctor will most likely be performing a regional block during the procedure as well. So he has a nice comprehensive protocol here, and then once he's been once he's been pre-medicated with the butorphanol and midazolam, we're going to go ahead and induce him with some propofol, titrate that to effect, and then we'll give the Serenia IV after that. So he has a good anesthetic plan. He'll have some sedation, analgesia, and muscle relaxation that'll hopefully help induce for general anesthesia. Since Mr. Ronald received some butorphanol in his pre-anesthetic medication today, we need to go ahead and log that because it is a Schedule 4 controlled substance since it's an opioid. So I'm technically not allowed to actually write in our controlled substance log until I am licensed, but you can see here I've made a copy. We're going to go ahead and put the amount used. So he received 0.52 milliliters, and then the previous amount that was in the bottle was 42.2 mils. So if we subtract 0.52 from that, that would be 1.68 mils. So we have here, it's butorphanol. There's 50 milliliters in the vial when we first open it at 10 mg per mil. It's an injectable drug. We have his last and first name. We could put the full client ID in here, but we go ahead and we put the amount that we used, the balance of the bottle afterwards, and then I need to make sure I take my initials, and then when our inventory manager goes over this, she'll also initial. We have to log every single controlled substance that we use. I'm going to demonstrate the parts of an anesthetic machine and the function of each one. This is considered an open breathing system, and it's a non-rebreathing system. So over in the wall here, this is an oxygen cable. And it kind of loops down and comes around into here. If we needed to just flush straight oxygen, we could push this as a little oxygen flush valve. So this bypasses the isoflurane. So if you push this button, it's just straight oxygen going through the system. If I were to turn it on here, you could see the ball going up, so that indicates that this flow rate's right around 1%. And then from there, we have oxygen flowing up through our vaporizer. So this is filled with isoflurane. So the oxygen goes through this chamber, which is filled with the liquid anesthetic, inhalant anesthetic. The oxygen flows through, and then we have a little turn dial gauge here that tells you the percentage of isoflurane. So we have really good control of how much gas is going into the system. If my oxygen were turned off, there would be no oxygen flowing through here, and even if I had my isoflurane turned up, it would not actually be flowing through the system because there's no oxygen to carry that gas. So from there, the oxygen tube comes around and it's hooked in up here. So if I were to push the oxygen flush valve, it would just be coming straight through here into the mouthpiece. And if this were hooked up to an endotracheal tube in an intubated patient, the tube would hook up right here at this point, come down this tube and inflate down at in the bag right here. And then we have a little pop-off valve here. So this is it opens and closes anything coming out of this tube. So if I were to close this and pump some oxygen through and plug the hole up here, then it would put some extra oxygen into this bag, and then we could use that to bag the patient and to give them some assisted breaths. If, however, this is open, all of the gas, the breathed out CO2 and the waste anesthetic gas would be pulled into this. So this is hooked up to our scavenging system. So we can follow this blue cord all the way around, and then it disappears into the wall right here. So we have an active scavenging system that's fueled electronically, and it just is constantly pumping all of our waste anesthetic gas out of our tubes. So that's why this is considered an open system, because we have oxygen coming, new oxygen flowing in, and then waste gas flowing out. So we don't use any rebreathing systems at my clinic just because we see a lot of cats and small dogs, and non-rebreathing systems are best for patients under about 20 pounds or so. And we see some larger dogs, but overall we see so many small patients that we just keep a non-rebreathing system. We did, however, in years past used to use a rebreathing system. Just kind of use this to show the different parts. So we would have oxygen coming in through this line here, and we also have pressure manometer. Since it's a closed breathing system, we really need to make sure we know how much oxygen is flowing into the system, and that'll tell us that part. We have an inspiration one-way valve here and an expiration one-way valve here, and then it would have a tube with a Y piece down at the bottom, and that Y piece would be connected to the patient and the endotracheal tube. So the patient would breathe in the isoflurane and the oxygen, it would go into the bag, it would be pushed back out through the expiratory one-way valve, and then it would get pushed back through into here where we have some carbon dioxide granules that would help filter out the carbon dioxide and the waste anesthetic gas, and then bring oxygen back into the line, and then the scavenged gas would be pumped out back down through the bottom. And then just since it's a closed system, you would need an emergency pop-off valve over here so you could open it up, and that would allow oxygen to flow through so that it would prevent pressure buildup in the system, or you could turn it this way and close it if you needed to keep that pressure in the system, maybe inflate your bag just a little bit so that you could bag your patient and give them a few extra breaths. Other options that we also have masks. So you could connect the mask, you could take your tubes, connect them to the bottom of the mask, and then this would go over the muzzle of the patient. And so there would be some gas escaping around the edges here, but this little rubber seal would help to hold most of it in. We also have an induction chamber here. The patient would be placed inside the chamber. We have a little door that pulls out here, and then you can put the patient in. You want to make sure that this is hooked up here, so that way we're still getting oxygen and isoflurane into the system. And then our scavenger hose would kind of be plugged in here. So we would be able to inflate this bag, kind of push iso and oxygen into the chamber, and then waste gas would be able to come back out the other end as well. So the idea would be the chamber would fill up with isoflurane, and the patient would kind of be immersed in it and breathe it in. And then after that's induced, we can take them out of the chamber, and then hopefully they would be anesthetized enough that we could intubate them. Prior to any anesthetized procedure, it's very important that you check your whole system for leaks. This is our open, non-rebreathing system. So I'm gonna go ahead and show you here. I have my oxygen hooked up down here, and I have my scavenging hose hooked up down here. So I'm gonna go ahead and make sure that this is pushed from open over to closed. So that closes off my scavenging system, so there's no exit for the oxygen and the isoflurane to get through here. And I'm going to plug this other opening with my hand, and then I'm going to push my oxygen flush valve and get this really, really taut. I'm going to go ahead and give it a little bit of a squeeze. I'm going to listen around the bag and at every connection around the tubing. And I hear just a little bit of air right here. It looks like it looks like that switch just wasn't pushed all the way over. I'm just checking every connection, and I don't hear anything. The bag is still just as taut and full as it was when I first started. And if I really wanted to, I could take some soapy water, put it around, each connection in the tubing here, and then I would do the same thing and see if any bubbles form from the air escaping through the soap. But this seemed to work just fine. We didn't see any leaks, I didn't hear anything, and there's nothing visually that I can see. And the bag stayed just as inflated from start to finish. I'm going to go ahead and show all of our anesthesia monitoring equipment that we use. This is a Vet Specs program, so we have a monitor here, and it's hooked up to all of our monitoring equipment. And it monitors kind of everything all at once for us. So the first thing I'm going to hook up is our SpO2. So this is the oxygen saturation in the blood, and it uses a little infrared laser. And this one in particular is meant to be clipped onto a leg or a toe. So I'm going to go ahead and take the caudal aspect of his hind leg here. And I want to find an area where there's not too much fur, it's not too thick, and that infrared light can kind of shoot through and check our oxygen perfusion. So I'm going to go ahead and turn our monitor on. You can see the SpO2, and this is the percentage. So this is the percentage of oxygen, of red blood cells that are oxygenated in the blood. We want that to be between 95 and 100%. So I'm going to be monitoring that, and he's at 98, so he has good perfusion. We're also going to go ahead and hook up a blood pressure monitor, because we want to monitor his blood pressure while he's under. So this machine also monitors it down here on the same screen. So I'm going to take a blood pressure cuff, put it down just distal to his hock on his foot, make sure it's nice and tight and that the Velcro is nice and secured on here. Then I'm going to put the sensor on the same foot, again just distal to that cuff. And I put the pressure side down because we want that to be up against the vessel on the caudal end of his foot. So the idea is it's going to pump the cuff full of air and restrict the blood flow to that vein, and then the sensor here is going to be reading it. It's going to slowly let up pressure, and then it'll give us a reading of when the sensor actually picks up pressure. So that's how we know the diastolic blood pressure or the mean arterial pressure of the blood flow, and it's going to give us a systolic and a diastolic reading, and then the mean arterial pressure as well. So it's starting. We have some really nice waves right here. You can see the blood pressure, and it's also kind of got nice symmetrical waves on the same level as the SpO2. So we know that that's reading well. So I'm going to go ahead and hit the blood pressure button, and it's constricting that vessel. And now we'll wait for that to give us a reading. We also have an esophageal monitor here. So we need to go ahead and we're going to wet this. So this monitors several things at the same time. This is just going to go down the esophagus. And since he's already intubated, we know that that tube is in his trachea. So this one should just cleanly go right down the esophagus. And I know that I need to get it a certain length down into his chest. We want to get it as close to the heart as we can. So that's probably about where it needs to go. I'm going to wait and get a reading on my monitor here. And those waves look a little off, so I'm going to try pushing it in just a little bit further and see if those waves normalize for us. Those look a little more normal. So we have a nice PQRST wave here. you can hear it also beeps in time with the heartbeat, so we can see the heart rate, and it's also an internal temperature monitor. So right here, it's starting to read that internal temperature with that probe. We also have a capnograph that's been sitting out in the room air, and normally down here it'll tell us it's calibrating when you first turn it on, and it's already calibrated. So now I'm really quickly just going to go ahead and insert it in between the endotracheal tube and our oxygen. So it's going to be reading the carbon dioxide, the end-tidal carbon dioxide, as it comes out. And that sensor is going to be picking it up. And it's also going to be checking his respiratory rate, so we can see those nice waves as David gives him a few breaths. We can see the waves kind of go up and down as he's breathing in and out. It's giving us our end-tidal CO2, and it's giving our respiratory rate. Okay, so his heart rate's looking a little low. Oh, it's going up now. That's good. Alright, so normally we don't have endotracheal stethoscopes here anymore, but it would be the same concept as this endotracheal probe that we're using for the ECG. So we're going to be, you would go ahead, it would be connected to the end of a stethoscope. You would thread it down into the esophagus close to the level of the heart, kind of just behind where the legs sit, into the near the thoracic cavity, and it would sit right next to the heart, and then you would listen to the stethoscope for those heartbeats, and that's how an endoesophageal stethoscope would work. And it would be, the same thing as what we're hearing here. It's giving us the heart rate with a steady beep anytime it hears that heartbeat. So that's how an esophageal stethoscope would work, very similar to our esophageal probe. And this is also giving us our ECG and temperature at the same time. If I also needed to take a temperature, we could just use a thermometer with a probe cover and take a rectal temperature if we needed to, but that's rendered obsolete with our helpful vet specs monitoring system. So that's how everything's hooked up and kind of how everything works. And now I'm going to continue to monitor all of these vital signs while he's under anesthesia. Alright, so I'm going to explain how to choose the proper size for an endotracheal tube and describe its function, kind of demonstrate how it works. So we have a variety of sizes of endotracheal tube. So they're normally sized by the millimeters on the inside diameter of the tube. So most cats are going to have a 4.5 millimeter diameter endotracheal tube. The distance between the nares on the inside of the nose, you can kind of hold the tube up and see like the inside diameter will be roughly about that size. You want to go ahead and select the size that you think it's going to be, pick one size up and then one size down, and then have them prepped just in case. And I'll demonstrate the function of this now. End of the tube has a little bit of a taper on it, so this makes it easier when you're intubating the patient and you're finding the epiglottis. Push the epiglottis down ventrally and then twist it back in for ease of insertion. There's also a little hole down at the end here. Just in case this front end gets blocked, there's another exit for airflow to prevent, any blockage of the airway. The main purpose of an endotracheal tube is to make sure you're isolating the airway, you're making sure that oxygen and vaporized anesthetic gas are going in, and that carbon dioxide and waste anesthetic gas are coming out. It also prevents any aspiration, if a patient regurgitates up and then tries to aspirate it back down, it's going to be blocked by the endotracheal tube. You can also use it to give the patient emergency breaths if they need to, or you can bag them, as they say. Bagging your patient in the middle of a procedure means that you're giving them some assisted breath. Once they're intubated, it has this helpful little cuff. You can just take a syringe with normal air, connect it, make sure it's nice and secure, and then push in. You can see that the cuff on the end inflates. You're not going to be able to see this end once it's in the patient, so we need to be able to push the air in, and then you listen for any breath sounds escaping past, the end of this cuff. Anything coming out, you can also smell any isoflurane that's escaping through. So we just slowly inflate the cuff a little bit at a time until you can't hear anything or smell anything else coming out. All right, so I'm gonna go ahead and place an IV catheter on a dog. This is my preceptor, David Zajac. He'll be overseeing me doing this. And this is our sweet guy. He's getting neutered today, and this is also my friend Lindy. Lindy is restraining the patient by the head, and she's also holding the arm off and rolling the vein for me. So I'm going to start by clipping the fur, buddy. I'm going to go a few inches up from the carpus and shave a generous area. Now that I've shaved it, I'm going to go ahead and scrub the area. So we're going to alternate back and forth from chlorhexidine scrub solution to isopropyl alcohol. I'm just going to wipe the area where I can see the vein. And I want to do this a minimum of 3 times or until no dirt or debris or hair comes up from the patient. This area is looking pretty clean, so I'll just do this final wipe. I'm going to go ahead and select a catheter based on his size. I'm going to use a 20 gauge. And I'm going to start out with a tiny 1/2-inch strip of tape secured to the underside. I'm going to leave it open on the top so that I can see a flash of blood through the hub when I need to. And I have all my other tape and things prepared here. I'm going to go ahead and visualize the vein, kind of feel for it too, and then I'm going to hold on the side with my thumb. I'm going to insert the tip, the beveled end, with the beveled end up into the skin and advance it forward until I get a flash of blood. I'm going to advance it just a little bit further. I'm still getting blood, so now I'm going to push the catheter tip in. It's not letting me advance, so I'm going to go trying a little more. And that time it let me push the catheter in, so I'm going to remove the needle, and I still have blood flow. And now I have a T-port that I've already pre-filled with saline, so I'm going to connect it here. All right. And I already have my tape on, so I can secure it to the skin. Wrap it around, make sure I'm securing the tape to itself and holding the catheter in place. At this point, I have a smaller piece of tape. I'm going to do a little twist, like a bow tie.
No, she just had them separated because she's just really...
Put it under the catheter to elevate it slightly at the hub so that that's easier to access later. All right, and then right at the place where I placed that catheter into the skin in order to maintain hemostasis, I have a Q-tip with some chlorhexidine ointment. I'm going to apply that right where the catheter was inserted and place a little bandage on top of it. Right. And at this point, I'm going to take a longer piece of tape. I've torn a little V into this. We're just going to secure everything onto the patient. And before I secure the T-port, I'm going to go ahead and take some saline. So this is heparinized saline. I'm going to go ahead and flush. I'm going to feel the vein more proximal on the arm, and I can feel that flush going through. Also, if I pull back, I get a little bit more blood into the catheter. So I know that this is patent still. I'm going to go ahead and put a little bit of vet wrap around this. Okay, and then we take a final piece of tape and secure the T-port onto the patient as well. All right, we've made sure that this is patent, and we've placed a cephalic IV catheter. I'm going to show how to place an IV catheter in a lateral saphenous vein on a canine patient. I'm going to shave the fur out of the way first. So we're going to shave the lateral aspect of the leg just above the hock. So now I can visualize the vein right here. And I have an assistant who's holding off the back of the leg. You can see it running up kind of diagonally along the lateral edge of that leg. So we're going to start with the scrub. This is dilute chlorhexidine scrub. So I'm going to scrub the area, and I'm going to alternate back and forth between the chlorhex, and this is isopropyl alcohol. I'm going to do a minimum of 3 times alternating back and forth, or until no fur or skin or dirt comes off the patient. All right, and there's nothing coming up on that cotton ball, so it should be nice and clean and ready to place this catheter. Okay, and I have all of my supplies all prepped. So I'm going to line this up with the patient's vein. I'm going to put my thumb right next to the vein to stabilize it. Put the beveled end of the catheter up. I'm going to insert it into the skin. Again, and I'm going to advance it forward until I see a flash of blood. Advance it a little further and I'm still seeing blood coming. And then I can advance the catheter into the vein. Alright, so I've pulled the stylet out. The blood is still advancing in the catheter. I'll have my assistant hold that off just while I prep this catheter. Okay, so this is a catheter with a T-port. I'm going to put it on the catheter, screw it in nice and tight. And then we have some 1/2-inch thick tape. I'm going to put under the catheter. And I fold it over to secure it in place. Making sure I'm taping the catheter itself down onto the skin. Now before I do anything else, I'm going to go ahead and use a saline flush to make sure that this is still patent. And this line has already been flushed through with saline. We're going to feel that we can feel the saline going through the vein and just make sure there's no saline bubbling up underneath the skin outside of the vein. It looks good. So now I'm going to go ahead and take another thin piece of tape. I'm going to wrap it around twice in a bow tie pattern, loop it under the catheter to elevate it slightly so that it's easier to place needles into that syringe. And then I have a Band-Aid here with some chlorhexidine ointment. I'm going to go ahead and place that right where the catheter went into the skin to help maintain hemostasis and hopefully prevent any flu. And we're going to use a longer piece of inch-thick tape to secure the whole thing onto the leg. Wrap it all the way around, make sure I get it over the catheter and the bandages. Okay, and then I'm just going to apply a little bit of vet wrap. One more shorter piece of tape. I'm just going to gently secure this catheter line onto the vet wrap so that there's no loose ends and nothing gets caught on anything or tug. And that's how you place a catheter in a lateral saphenous vein. Alright, so this is Miss Libby. She's getting a dental today. So we're going to start her pre-anesthetic medications. So I need to give her some Serenia subcutaneously to stem off any nausea. Give a sub-Q injection. I'm going to pinch her skin in between 2 fingers. Make sure I tent it. I can visualize the skin. And then I'm going to insert the needle at a right angle to the skin. I'm going to pull the plunger back, make sure I don't get any blood. Then I'm going to depress the plunger. Oh, good girl. And then pull the needle out at the same angle. And you were a very brave dog. Alright, so now Miss Libby has had her Serenia and famotidine and metoclopramide in for about 10 to 15 minutes. So I'm going to give her an intramuscular injection. So per the doctor, this is hydromorphone and midazolam. It's a combination in this syringe, so I'm going to give that intramuscularly. So I go ahead and I palpate the spine. And then I feel right next to it, so I'm going to put the injection right in the muscle right here. So I insert the needle, Again, I pull up to make sure I don't aspirate back any blood. And then I slowly depress the plunger, give that, and then pull it back out of the muscle. Alright, so we gave Libby her pre-medications already. You can see she's feeling the effects a little bit. So now I'm going to be giving her intravenous medication to induce anesthesia. So this is propofol. I already have an intravenous catheter placed, as you can see. We're going to be giving anywhere from 2 to 4 milligrams per kilogram for her size. I'm going to try to give the lowest amount possible. And this is an emulsion, so I want to make sure that I rock it and mix it right before I give and get any air bubbles out of the syringe because we don't want to give those intravenously. Alright, so to start, I'm going to inject the propofol. No, Libby. So I'm going to put it in the catheter, and I'm going to give it very slowly. Okay. And I'm going to go ahead and just give about 1/3 of that volume, and then we're going to use, this is heparinized saline. We're going to flush all of that out of the catheter and into her vein. And then we're going to monitor her and see how she does from there. As
She might go through an excitement phase. Yep. So we're going to give her a little more propofol. We're going to bolus it slowly. We're going to try to push her through the excitement phase as she gets into a good plane of anesthesia. Okay, so giving about another third, and then I'm going to take that out. We're going to flush one more time with saline. She starts to be seeming a little more sedate. The propofol back in just in case we need to give any more, and she seems to be pretty sedate here, so we're going to check her jaw tone and see if she's ready enough for intubation. Okay, so that's how you induce anesthesia. Now, as you can see, Mr. Ronald has been induced with propofol, and he's feeling pretty sleepy, so we're going to go ahead and intubate him. I've selected a size 10mm cuff because it's roughly the distance between his two nares. We apply some sterile lubricant to the tip of the endotracheal tube. I have an assistant elevating the head for me. She's holding just behind the canines. So I'm going to grasp the tongue with some gauze, hold it out of the way. I'm going to use a laryngoscope to hold the tongue down and to visualize the epiglottis. Alright, so I'm going to use the tube to push the epiglottis down ventrally so that I can visualize the vocal cords. And then I'm going to gently advance it forward. If I were to feel any resistance, I would stop right away. And I can feel the air coming out of the tube as he exhales. So now I'm going to secure this onto his head. He's a dolichocephalic breed, so I could tie this over his muzzle to secure it, but we're going to have some monitoring equipment by his tongue and his mouth, so I'm tying it behind his head. To our anesthesia machine and get some oxygen flowing. So now we can see, I can feel the breath coming through the endotracheal tube, and I can see it fogging up, so I know that it's in the trachea. So I'm going to put, this is just a syringe, I'm going to put some air in here. I'm going to inflate it. You can see this little cuff on the outside, kind of lets you know how much air is in there. Now we turn the isoflurane up. We're going to turn it up to 3, since we're inducing him, 3%. And we have oxygen flowing so that we know that the isoflurane gas is also going into the line. I'm going to close this system off and push my oxygen flush valve. Okay. To get some air into my bag. Okay, so I'm inflating my bag here a little bit, and then I'm going to open it back up, give him some breaths, and I can see his chest lifting as I'm breathing for him, so I know that some of the air is going down into the trachea and into the lungs. And I can smell a little bit of isoflurane, so I'm going to go ahead and inflate this cuff just a little bit more. The outside of this cuff is also getting a little more full, so that's probably right around how full it needs to be. We'll go ahead and check again. Okay. I can hear a little bit more air passing through here, so I'm going to inflate that just a little more. Alright, so I don't hear any more air coming through, and I didn't smell any more isoflurane. There's still a little bit more give here, so I don't think it's overinflated, and I think it's inflated just enough that we don't have any leaks. Eye lubricant, these are artificial tears. I'm going to open up his eye, make sure I keep the nozzle away and don't scratch his cornea at all. Get a good amount of lubricant into that eye. We'll do it on this bottom one as well. Now just make sure his eyes don't dry out while he's under. And now we're going to go ahead and prep him for surgery. Alright, so I'm prepping. This is Miss Iris, and she's getting spayed today. So I'm going to prep her for her surgery right now. So the first thing I'm going to want to do is palpate her bladder. It feels like it's not very full, but I'm going to express out what I can here. I'm just getting very small amounts of kind of dark colored urine. Nothing to be concerned about. And with the bladder, once I isolate it, it'll feel kind of like a tiny water balloon. I want to cradle it in my hand
and apply slow, steady pressure from the cranial end to the caudal end. So I got all of the urine out that I could. Now I'm going to go ahead and shave the patient. So since she's a female, we're prepping her for an ovariohysterectomy. I'm going to go ahead and start up at the xiphoid process. My margins are going to go along her rib cage, all along the abdomen, up about an inch or so on her legs since she's tiny. And then I'll make sure that I go low enough and clip around the vulva as well. And since she has this long hair, I'm going to make sure I clip some extra if any of it's in the way. So first, I'll go with the grain of the hair, just to get the vast majority of it out of the way. And I'm being careful not to get too close on the first pass, to make sure that I don't accidentally clip one of her nipples or cause any razor burn on her skin. I'm just going to shave a little bit up the sides of the legs to give the doctors nice wide margins. And I'm going to be gentle with this flank skin right here. Want to make sure I don't go at a wrong angle and cut her there. I'm going to shave the area immediately around the vulva, just at the top. Okay, so I kind of have my margins now. Now I can start to clip a little bit closer. I'm going to take the clipper blades and go opposite the grain of the hair and get a little bit closer to the skin. And sometimes pulling the skin taut with your other hand can help you get a little bit closer, and it minimizes any chance of the skin wrinkling and causing razor burn or cut. And as you can see, I'm wearing gloves and I'm wearing a smock, so that if any hair gets on me, I can take the smock and the gloves off before I transfer the patient to the surgical ward, and I maintain asepsis as much as I am able. I'm going to take a vacuum or a lint roller and just get all of this excess hair off. Get it as short as possible and as close to the skin as possible. The patient's skin's never going to be completely sterile. We want to get it as close to sterile as possible before we get her into the surgery suite. And then I'll do a quick pass with the vacuum at the end as well to get all of the excess hair from around her. All right? And now that we've gotten as much hair out of the surgical field as possible, I'm going to begin my sterile scrub. So here I have chlorhexidine scrub, and we have isopropyl alcohol. So I'm going to start with the chlorhexidine, taking one sponge at a time. I'm going to scrub where the incision site will be and make circular motions all the way around. And as soon as it touches hair on the outside, I toss it, and then I take my alcohol. I'm going to do the same thing, start in the middle, make circular motions all the way around. I'm going to alternate back and forth. I want to do this a minimum of 3 times with each type of cleaner, or until the skin appears clean. I'm just going to do a few extra steps because I'm still getting tiny hairs here and there. One last scrub.
Oh, come on.
Alright. So now that was our initial scrub. We're going to prep her to move her into the surgical ward. And while I do that, I'm going to take another gauze of the chlorhexidine scrub. I'm just going to place it along the area that I scrubbed here. Try to keep that sterile as we move her into the surgery suite. Alright, so now Iris is all ready to be transferred into the surgical suite. Okay, now we're going to disconnect her tubes. I'm going to very carefully grab her. So one arm's cradling the bottom end of her body and the upper, making sure I'm cradling her head. We're going to move her into the surgery suite. There we go, Iris, good job. We got our nice soothing music in here for the doctor. Yeah. Okay, there we go. We're moving the tubes back up. I'm just going to keep a hand on her while we hook her up to everything, just in case she decides to wake up. And now we just need to make sure that we tie her down to the table. So our ties loop around. We want one to be higher up on the leg.
I'm going to be careful not to tie it too tight on this leg since this is where her fluids are going to be going in. We want it to be looped on at 2 different points. And then we're going to lift it up. We don't want it to be too tight so that she doesn't feel some muscle stiffness when she wakes up, but tight enough that if she wakes up in the middle of surgery, she'll still be nice and safely secured to the table. And I'm tying her down again. The first tie is going just above her hock joint, and the second is down on the metatarsus. So she's all moved onto the table and secured. So now we're going to go ahead and prepare her final scrub and get her ready for surgery. So now that she's all prepped for surgery, we're going to go ahead and do the final scrub. That's the procedure at our hospital. So Dr. Weil is currently getting scrubbed and she's about prepped for the surgery. So while she's doing that, I'm going to do a final scrub on this iris here. And now I have more isopropyl alcohol. I start at the incision site, go up and around, making sure never to touch the inside part that I just scrubbed. We're going to alternate back and forth between chlorhexidine and alcohol. Circular motions from the inside all the way to the outside. If they touch hair at any time, then go ahead and toss it and grab another one. You want to do this alternating back and forth a minimum of 3 times. And then one final scrub. And then this iris is all ready to go. The doctor will be right in. I'm going to go ahead and monitor Otis while the doctor gets ready and while they get ready for that mass removal. So I'm monitoring his vitals right now. His heart rate earlier was dipping down to 60, which was getting a little low for us. So we gave him a little bit of atropine IV, and it jumped back up. You can see it's at 110 now, kind of hovering around there, and it's been staying up at that level, up above the 100 since then. His temperature is reading at 96.8. This particular probe tends to read a little bit lower. It's been above 97. Which is kind of the lower cutoff. I'm going to go ahead and take a rectal temperature in a little bit here just to make sure he's still at a good temperature. His oxygen perfusion's up at 99%. That's good. We want that to stay between 95 and 100%. His gums are nice and pink and moist, and I'm just making sure his capillary refill time is less than 2 seconds, and it is, so he's holding nice and stable up there. We can also come over here and see that his blood pressure is good. Systolic is 89, diastolic is 57, and MAP is at 67. We like that MAP to stay above 60, and if that starts to dip down, then we'll kind of let the doctor know, but he's kind of been going down and then back up again. And then his respiratory rate's around 37. Normally that's from 8 to 20, but he's kind of been having some shallow panting throughout most of the procedure. You know, we will give him a few breaths here or there. He's been around 46 or lower. Normally on a non-anesthetized patient, that's going to be between 35 to 45 millimeters of mercury as far as the end-tidal carbon dioxide goes. Sometimes when they're anesthetized, though, that can get up to 55. We like to keep it, you know, below 45. So David is inflating the bag, and he's giving him a few breaths. We call that bagging the patient. So he's pumping more fresh oxygen and isoflurane into the patient's lungs. That's helping to get more oxygen perfusion, lower the end-tidal CO2, and it prevents atelectasis, prevents the lungs from closing up and being unable to pull in more oxygen. All right, so this thermometer says that his temperature is at 100.7, which is good. Normally anywhere from 99.5 up to 102.5 is the normal internal temperature. Overall, it looks like Mr. Otis is staying nice and stable during his surgical process. Okay, so Mr. Batman's going to be waking up here, but as you can see, he's still intubated. The cuff is still inflated, so that was preventing any regurgitation from coming up his esophagus and then him breathing it back down into his trachea. And it was also allowing us to control his airflow and the amount of anesthetic gas that he was receiving. If he were to go into cardiopulmonary arrest and have any issues, I could hook up this ambu bag, give him a few rescue breaths, and control his breathing that way. And we would want to make sure, you know, we're giving him rescue breaths at a good interval, and probably give him 10
2 breaths to every 30 compressions. You know, we could have someone breathing for him and then giving compressions just behind the axillary region here on the thorax and in the lateral position. You know, we would have good leverage. Make sure we would push that thorax down to push the lungs down and then contract them back up to help him breathe a little bit. But we could also just give him rescue breaths. When we're pushing down, that would kind of just be helping to jumpstart his heart and then giving him breaths. I'm going to scrub in to sterilely help Dr. Weil on a neuter procedure. So the first thing I need to do is put my mask and my cap on. Want to make sure it covers my nose and it's nice and secure so that if I breathe or sneeze, no air comes up from underneath. Then I'm going to put a hairnet on, make sure all of my hair is inside. None is coming out of the side and none's coming from out of the bottom. So now that I have this, I can begin to scrub my hands. So we have pre-made surgical scrub, 4% chlorhexidine gluconate. So inside this packet there's also a little nail brush, and we have a handless sink down here that I'm opening with my knee. So I'm going to first begin by wetting my hands and then using the nail brush, and I'm going to just go ahead and remove any dirt or debris from underneath the nail bed. Okay, so I have my left hand done. Now I'm moving on to my right hand. Repeat the same process. So once that's done, I'm going to remove my brush. I'm going to use the soft side to scrub the fingers and the back of the hand. Just kind of apply the cleaner all the way down the arm and let some of the antiseptic start working. Okay, and I'm going to go down to an inch or 2 distal to my elbows. So now that I have the antiseptic on that side, I'm going to begin to start scrubbing. So this is a soft brush side. I'm going to have all my fingertips together, and I'm going to scrub 10 times on the tip of the fingers, making sure that I get underneath the fingertips as well. So I'm going to scrub a little extra to make sure I get under the fingertips. So now I'm going to go ahead and start with my index finger. I'm going to brush each side 10 times, visualizing the sides of my fingers as 4 different sides of the finger, 6, 7, 8, 9, 10. Move on to the next side, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and the back. I'm going to do this for each finger on each side of each finger.
Oh, I got that on my Netflix already. I like lady movies, like girlfriend type movies, you know.
And then on this side, I'm going to go all the way down the lateral surface of my hand. Okay, now I'll move on to the thumb. And now I'm going to go down the other side, the other lateral side of my hand as I scrub this side of the thumb. Now I'm going to scrub my palm 10 times and the back of my hand. And I can add a little more water to make this soap come out a little bit better. Okay, now I'm going to go down the back of my arm on one side and another. And the last side. Okay, now I'm going to go ahead and do the same thing on my right hand. Start with the fingertips. Do it at least 10 times, making sure that I get that brush underneath all of the fingertips. So I'm doing a few extras on the fingernails just to be on the safe side. I'm going to start with the index finger. 10 scrubs on each side.
And then on the lateral edge, go all the way down. Okay, and I'll do the same in the middle finger, moving on to the ring finger. And the lateral side, I'm going to go all the way down my hand. Move on to the thumb, and the other side, go all the way down the side of the thumb. I'm going to get the whole back of my hand, and then my palm. I'm going to go down my arm, last side of the arm. Okay, and I'm making sure that my hands are away from my body and that the hands are up above the elbows the whole time. So now I'm done with my scrub brush. I'm going to rinse my hands starting at the tips of the fingers, going all the way down the back of the hand and up my arm so that it drips off the elbow. You never want anything to run from the elbow or the hand to the finger because then the contamination can get pushed up to your fingertips. Now that I've rinsed off, my hands are sterile. I'm keeping them away from my body and my hands up above my elbows. And now I'm going to go ahead and move into surgery. Alright, so now in the surgery suite, I've kept my hands nice and sterile. So we have a gown and towel pack over here that's already been opened on the outside. So the inside is sterile and I can go ahead and open this. Making sure not to touch anything down below. I'm going to go ahead and grasp the towel from inside the pack. Let it fall open. Use this one to dry off my fingers. Drying off all 4 sides. Okay. And then I dry the palms in the back of the hand. And then I go down the arm. Okay. Now I lift the towel away, keeping it lifted from my body. Grasp the other end in the other hand and come up and dry the fingers of my other hand. One side at a time, visualizing 4 sides on each finger. Okay, and then the palm, and the back of the hand, and then down the arm. Okay, now I discard the towel and don't touch it again. And now with the gown, I can see the strings from the top. I'm going to pull it up and out. Pull the strings out and let the gown fall open so that the inside is facing me. I'm going to slip an arm into one sleeve and an arm into the other sleeve and pull them apart, pull in. I'm going to keep my hands in the sleeves because I'm going to close the glove. So now I'm going to have a circulating nurse tie the gown on. She starts up at the top so that she's only touching near the neckline and the back of the gown. With my left hand still inside the cuff, I'm going to go ahead and grasp the inner cuff of the right glove. And I'm going to place it so that the palm side down on the right glove. So I need to keep in mind thumb to thumb, palm to palm, and fingers toward the elbow. So now I need to use the cuff to grasp the inner side of this glove. There we go. And then with the other one, I grasp the bottom cuff of the glove. And then with the assistance of the left hand, flip that cuff all the way over so that it covers the cuff of the right hand. And then as I pull with my left hand, I advance the right hand forward. And now I can push my hand out. Now with my right hand, which is gloved, I can take the inner folded cuff of the left glove and place it by my left hand. Again, thumb to thumb, palm to palm, and fingers facing the elbow. And then I grasp the inside with my still covered left hand. gloves. Now the doctor is going to come in. She's scrubbing right now, and she's going to put her gown and sterile gloves on as well. So I'm also going to go ahead and open up this pack. And the sterile inside. To get it all prepped. Grasp the outside fold. Okay, so I'm going to arrange everything, have all of our instruments laid out in a nice, easy to use pattern. I have my table all set and ready to go. I have my draping mat already scissors and towel clamps ready to hand to the doctor. So, we'll go ahead and load this scalpel onto the scalpel handle for the doctor. So it pulls through, snaps in, and then presses in on this side. So to pass this to the doctor, I hold it so that the sharp end is away from me, and then I pronate it and hand it to the doctor. So now there's a little excess bleeding, so I'm going to blot this for the doctor using some sterile gauze, and once it's been used, it goes off to the side. We don't use that again. So if this were a more extensive surgery or an abdominal surgery and Dr. Wiley wanted some irrigation, we would have a sterile bowl which we would keep off to the corner of the table, and we would use sterile sage carefully poured in so as not to spill any moisture onto the rest of the instruments. And then we could have the circulating nurse give us a sterile syringe, which I could then use to drop some solution and to irrigate the site for the doctor. But seeing as this is a neuter procedure on a male canine, we're not going to need any irrigation. So in order to pass these medicine ball scissors to the doctor, I'm grasping just behind the hinge with my thumb and my pointer finger, and then securing the rest of it by having my fingers on the back of the instrument. The loop handles are down, and the curved end of the blade is facing toward my thumb, so that when I pass it to the doctor, it'll already be in the proper placement for her to cut the tissue. I put it in soda draw. We're going to do a marking block, so I have the circulating nurse holding up the bottle. Going to insert the needle. This is sterile needle and syringe. I'm going to draw 0.5 cc's, and then you're going to put that back on carefully. Alright, and then I carefully put the cap back on. Alright. And the sterile nurse gives me another sterile needle, and I'm going to put that on instead. Alright, so here I have a threaded needle. This is all prepped in the needle holder for the doctor. And this is all prepped with the needle held about 2/3 of the way through the needle holder. I have the first box slot clipped down, and it's prepped so that when I hand it to Dr. Weil, and she's right-handed, it's all ready to thread the needle through the incision. While we're sterile and Dr. Weil is performing the surgery and I'm the sterile assistant, I need to be really mindful that I'm not touching anything that's been touched by someone outsider that's not sterile. We need to maintain sterility at all times. So I'm making sure that anything that touches the table is sterile. And if anybody breaks sterility, or if anything happens, if a glove were to get broken, we would have a circulating nurse or an assistant, non-sterile assistant, open up the outside of the pack for us, and then I could open up the sterile inside. I would help Dr. Weil by assisted gloving, pulling the glove open so that she could re-glove her hand if she needed to. I'm just making sure that I stay sterile and that she and the table stay sterile, so that we maintain asepsis during the entire.
Alright, so we have 2 cats in today for their surgeries. This is little Smokey. She's a female kitten and she's going to be getting spayed today. And then this is Mr. Hank. It's okay, buddy. He's getting neutered today. And he's a little nervous. We just temped him, and we're going to be giving him his pre-medication for his neuter shortly. Alright, so here we are in the surgery suite. This is our lovely Dr. Moore. And little Miss Smokey has been all prepped and scrubbed and draped, and she's all ready to go for her ovarial hysterectomy. Alright, so this is little Mr. Hank. He's been PA'd, and he's been sterilely prepped, and he's been draped, and now he's about to undergo his neuter with Dr. Moore. Finished up with the canine neuter. This is our surgery suite. And as you can see, it's a little messy, so I need to show how to properly clean this up. Set this here so you can kind of see. So I just take anything that needs to be thrown away and put it in the trash. Turn off any equipment that's still on. Any medications that were given, if they're a controlled substance, then I have to get rid of them accordingly. Any medications just get put into something that they can't get siphoned out of later. Controlled substances have to be removed in another manner, but we didn't use any in here today. And I just put the needles in the sharps container. Endotracheal tubes. I'm going to take these into my surgery scrub area later and properly wash them. And then for the rest of the surgery suite, any towels that we use, so all of these can go into the laundry. And then I have some ties here. Going to remove these and place them in their proper place. And then we also have our IV fluids. We use Normasol R. Now that this has been used, the Venaset and the bag are no longer considered clean for a surgical patient. So we're going to go ahead, I'm going to take this and I'll later remove the Venaset, put a new one in, and then this can be used for subcutaneous fluids instead if we need to. We use vet specs as our monitoring equipment, and it's kind of scattered all over the place. So we're going to use, I have my chlorhexidine spray, so you can see we have it labeled chlorhexidine, and this is for surgery only. We don't take this cleaner anywhere else in the hospital. I'm going to clean the outside of the rubber casing, the outside of the clip, inside of the clip. Anything that was touching the patient should be cleaned. All the equipment should be wiped down at the end of the day so that I avoid spreading any bacteria around. We want to try to keep the surgical suite as clean as possible. So now this has all been wiped down. I'm going to place it neatly off to the side so it's easy to use next time. And then any excess equipment over here can be neatly put away. Okay, and then in order to clean the tables, we use a different antiseptic solution. This is our Vedco D256. It's germicidal. It kills bacteria and viruses and fungi. So I'm going to use this to clean our Mayo stand and surgical table. And the surgical table has divots in it that are meant for the blood to pool from surgery. So I'm making sure I'm going around, really cleaning all down in these divots. Even if I don't see anything, I need to wipe the whole surface, make sure it's sterile. Wipe the drain section here and the outside. I'm also going to clean the surgical light handles here. Because as sterile as we try to stay, hands have touched that area. I'm just going to directly spray my cleaner right onto here, all the way around. I'm going to sterilize anything that I think someone might have touched. And then we also, it appears, used a V-tray. So I'm going to spray and sterilize this. These tubes are going to go over here by the rest of our things, and they're going to get cleaned along with the endotracheal tube in our surgical scrub area. And I also have a trash can, so the kick buckets, a trash can, and a biohazard bucket down below. So I'm going to remove this trash. And then we do have some removed body parts in here from the neuter procedure in a biohazard bag. I'm going to go ahead and tie it closed. This is going to go outside to a freezer, and we have a biomedical waste company that comes and picks this up and disposes of it. So after all of this, I'm going to need to sweep and mop and sterilize the floor. And I'm going to clean some of the surgical instruments. So this is our scrub area, As you can see, we have a microscaler over here. So I'm going to use a scrub brush, and we have some Miltex instrument sterile cleaner. This also includes a lubricant in the cleaner. So I'm going to go ahead and put it on my scrub brush. And then for instruments such as these dental extraction forceps, I'm going to make sure I scrub the hinges really well, paying particular attention to any area that would have touched the patient or been in the patient's mouth. So the forceps right here up top, I'm making sure that I scrub in the grooves really thoroughly. Then I'm going to clean the whole surface of the instrument, including the handle. Then I'm going to place it in the scaler. This also has a sterile, not sterile, but has an antiseptic cleaning solution in my scaler here. Things like Alice tissue forceps. I'm going to scrub anything that touched the tissue on the patient, so the part up top, the forceps themselves, and then I'm going to make sure I get the box lock and the hinges really well. I want to scrub them open and closed. And then I'm going to get the stems and the handle pieces as well. And I'm going to do both sides. And again, scrubbing that hinge really thoroughly. All of these are going to get rinsed and put in the microscaler. And then we're going to go ahead and close the microscaler. And we said we have a timer for 15 minutes. So that'll go ahead and now scale all of our instruments. Now that our instruments have been in the scaler for 15 minutes, I can go ahead and take them out. So this has a little tray that you can just pull right out of the scaling solution. I want to make sure that I rinse really thoroughly. So I'm making sure the water is going over all of the instruments and I'm rinsing all of them off several times. Okay. And then I can go ahead and set my instruments down to dry. I have a little drying station over here. So I want to make sure that when I set the instruments out to dry, I open them up so that the hinges can get dry. And this will prevent rusting of the hinges. We want to make sure these surgical instruments last as long as possible. So now these need to be set out to air dry overnight, and tomorrow we will come back, wrap them, and then put them in the autoclave for the final sterilization process. In order to wrap a surgical pack, first of all, we have to make sure that we have all of the proper components. So this is our scrub book. Each practice should have its own protocol for different packs that they want wrapped. So this is our general surgery pack. You can see I already have all of my instruments assembled. I've counted all of them, so I know that this pack in particular takes 30. I have my sterilization strip in here. I want that to be in the center of the pack because that's how we know that it got hot and pressurized enough to sterilize that piece of paper and to make sure that all of the bacteria and everything all the way within the pack have been killed and that it's been sterilized throughout. Now in order to wrap the pack, as you can see, all of my instruments are lined out in here. I'm going to go ahead and fold this towel over, kind of tightening it over the side, and then I have another surgery towel or huck towel. We're going to pull it over the top side first, keeping tension on it, keep it nice and tight, and then you fold it over so that there's a tab right here. Then keep pressure on it. We're going to go ahead and fold this other side over. Keep it nice and neat, and we want everything to be kind of tightly held together so when the pack is all wrapped it's as small as it can be, and that way we can fit the most packs possible inside of our autoclave. Then holding tension on the other side, I'm going to pull that over as well. Alright, and then for our final side, go ahead and pull it over, still kind of keeping everything in our pack nice and tight. Can fold the edges over a little bit, and then we're going to take this fold, tuck it under the first one, and leave a little pull tab. I'm just going to go ahead and put one little piece of tape down here. That's another way that we know that this layer is sterilized, and that's just enough to keep the pack kind of closed right here. Now we can do an outside layer of paper. We're going to take the top end, fold it down and over, keep it nice and tight, keep pressure over the pack. Again, keep it as small as possible while we're wrapping. Okay, and we're going to go ahead and fold little tab down on this side, and then I'll fold the first side over.
keep that nice and taut. And then fold, so there's a tab to pull on that side. Fold the other side over. There we go. Pull that side back as well. All right, and then we just have our fourth side here. I'm gonna pull up and over. You can kind of crease paper in as you go to help it fold a little bit better. Okay, and then pull this up and over. And then, again, we're gonna take this layer, find that first fold, kind of tuck it under until we have a little pull tab right here. So someone can open that right up and pull it out. I'm going to go ahead and secure this with some tape. It's a nice big piece of tape. I'm going to wrap it all the way over, kind of fasten that and secure it on one end and the other one. When this is in the autoclave, it's going to be subjected to a lot of heat and a lot of pressure, so we just want to make sure this is all wrapped up nice and tightly, and that as you know, the material kind of shrinks and enlarges again with the heat, that things don't kind of pop open. And then I'm going to put another piece of tape up at the top because I need to label the contents inside. So this is called our general surgery pack. I'm going to put the date that I wrapped it and my initials. And then we know that this is ready to go and get loaded into the autoclave. In order to wrap a surgery gown, it first needs to be held up so you can figure out which side is the inside and which side is the outside part. I can tell this is the inside part because it has the inside seam. So I'm going to go ahead and find the shoulder seams. You can see right here. We're going to accordion them together on both sides. Hold those together. And then pull those two pieces together as well, so everything is accordion folded together. Then I'm going to bring the strings around, hold the whole shoulder, and then we're going to go ahead. So this would be where the arms would go in on the inside. So you follow your fingers down to the armpit part of the gown, and you can hold it up. And at this point, I'm going to hold both sides in one hand, come down and adjust my hem down at the bottom, so that those seams match up nicely. And then I'm going to put my gown down on a folding table, and from here I can straighten everything out, make sure all the seams align well, and then I'm going to pull the shorter side over, fold the whole gown lengthwise, straighten it out, and from here we can accordion fold the gown so that the top comes over, and then one more time, and we flip it so that the top of the gown is on top. Want to lay the strings out nicely and keep the side strings in the way too. So that's how the gown is folded. Once our surgical gown has properly been folded, we then need to wrap it. This is some pre-cut autoclave paper, and I have 2 layers of it. I'm going to put it so that the tips are facing up and down for me, kind of like the points of a compass. And then I'm going to go ahead and take my gown, put it in the center of the pack. We also need a surgical towel so that the surgeon can dry their hands when they open it. So this has been accordion folded as well, lengthwise, side to side, and then long ways as well. That's going to be placed on top, and we're going to put a sterilizer strip inside as well. So this is a sterilizing strip, but we're going to put it inside this pack. So now that we have everything ready, we can go ahead and wrap. I'm going to take the top part, I'm going to pull it over the pack, and I like to just kind of make little folds in the paper here so that it stays nice and flat. We can pull this end over as well, and then this will fold down. And then we're going to go ahead and pull this side over. So that's my right side. We're pulling it over the pack, and you can kind of crease the inside there so that it folds over nicely. We want to try to keep the pack nice and tight. so that it stays as small as possible, and that way we can fit as many packs as we can into our autoclave. Alright, and then I'll pull the left side over, so I'll go ahead and pull this down, kind of crease that, push that in as I pull this end over. Again, keeping the paper nice and taut, and then pull that side over. Okay, and then for the last side, go ahead and crease this, maintain tension, and pull it up and over the rest of the pack. There we go. Keeping our lines kind of aligned there. And then I'm going to follow it down to that first crease that we made. We're going to tuck it under and push it all the way in until we have a tiny little pull tab. I'm going to take a piece of tape and just secure this end here, and we're going to do the whole process one more time. So this is nice and closed up. Now I'm going to take a nice long piece of autoclave tape, wrap it all the way along from the bottom over the top edge to keep that nice and tight and secure. I'm going to do the same thing on the other side. Alright, so that's nice and tight. As it gets sterilized in the autoclave, the pack will pop open now. And then I need to label it. And while I'm at it, I'm going to go ahead and have this just wrap around the sides as an extra precaution. And then we're going to go ahead and label this with what kind of pack it is. So this is a gown and towel pack. I'm going to put the date on here and my initials so that people know what type of pack it is, when it was wrapped, and who wrapped it. Now we can go ahead and load our autoclave. Alright, so this is our sterilizing autoclave. So this is a gravity displacement autoclave. It's used to sterilize all packs that have metal inside them and nothing with plastic, components, anything that would melt in high temperatures would not be safe to put in an autoclave. So it has a door that opens with a seal. And the idea behind this is that you let it fill with water, and then we close it, and this door has a sealed edge here. So we close it up, it puts water inside, heats it up with electricity, and then turns the water into steam, which then expands and pressurizes the chamber, and everything within, all bacteria and other organisms are sterilized by the heat and the pressure of the autoclave. And then we have little dial on the side that shows the temperature and the PSI. We set the timer for about 45 minutes and it can get up to the proper temperature and pressure. And at the end of the cycle, the only thing we need to be careful of is opening this door. We need to do so slowly because as the door opens, pressurized steam can come out and it can burn us. So we need to be really careful that we just open it the barest amount, let it vent some steam before we open it all of the way. And then when we open it, we want to make sure that we let it air out so that the things inside aren't too hot when we reach in and we don't burn ourselves. I'm going to go ahead and take some of these, and I'm going to start with the largest one first, so our general surgery pack. We're just going to go ahead and place this inside the autoclave, and the idea is we want to fit as many packs in as we can without compromising the integrity of the pack. So I want to make sure there's still a little bit of room in between packs. And if I had some smaller instruments, I could kind of fit them in here. For right now, I'm going to leave it because I want to make sure that there's enough room to get good air circulation all around in our autoclave. So now we're going to go ahead and you always need to make sure that your reservoir has enough water in it. So there's a water fill tank up here. I'm going to go ahead and just wipe that level to check it again. And it's right about here, so it's halfway between the minimum and the maximum, so that'll be fine for the purposes of this load. I'm going to go ahead and turn it to fill water. I can hear it bubbling, so now water is being released from the fill chamber down into the bottom. And I can see it creeping up. I'm going to wait until it hits this little line right here. And then once that gets close, I can flip it to the steam cycle, which will close off the water from filling into the rest of the chamber. Now I'm going to close the door. I'm going to make sure it's sealed nice and tight. Not so tight that I wouldn't be able to unscrew this again afterwards, but tight enough that this door is nice and sealed. So that's really well closed up. We have it on our steam section, We have our autoclave preset to 273 degrees Fahrenheit, which is definitely adequate heat in order to kill any organisms that are in here. And then I'll go ahead and hit my start button and flip my timer onto our preset amount, which is 45 minutes. So as it heats up, the water's going to go ahead and vaporize, turn to steam. It's going to get really hot and pressurized in that chamber, and then it'll start to vent the steam out eventually, and the timer will let us know when it's done, and I can come over to the dial, make sure it's reached the proper temperature and pressure. And then once that's all finished, we'll open the door, let it vent out the steam, being very careful not to be anywhere near it and burn ourselves. We can then further open the door, let everything air out. There is an extra exhaust if we want to help it, exhaust some of the steam before we open the door. And so the optimum temperature for the autoclave is going to be about 250 to 270 degrees Fahrenheit and up to about 32 psi as far as the pressure goes. We usually let it run for about 45 minutes. That's the preset amount of time that we run the autoclave. In order to maintain our autoclave, we need to make sure that we clean it regularly. We prefer to do ours every 2 weeks, and we have a little log. So we write the date and the initials of who cleaned the autoclave and when. So in order to clean the autoclave, you first need to drain all of the water out. So we would just twist this to loosen it. It would drain all of the water from the tank, and then we go ahead, fill it up with new water, and then we would use a packet of our Chamber Bright, which is the cleaner that we use. So you go ahead, you take all of these little trays out, any other add-ons or shelves that you put inside, and then I would put the contents of all of one of these in the bottom of the chamber, close it, and then once that's in, we would make sure we fill the water to the water fill line again, close it like we normally would to run a regular load, and then again start it and set it to 45 minutes. After it's run, we then open it up, let it cool down, remove all of the water one more time, and then fill the tank with new water, and then it should be good to go. If there were any more serious problems with the autoclave, such as if it wasn't getting up to the optimum temperature or pressure in the middle of a run, if we were having difficulties turning it on, if there seemed to be any problems electrically, then it needs to get sent out and serviced with the manufacturer. We have this machine under warranty, so we would send it in, they would send us a loaner while they serviced it, and then they would send it back. But hopefully, if properly maintained, this machine should last us for several more years. And as you can see, the lines on the tape have now turned black, so it's been sterilized, at least on the outer layer. And I'll go ahead and show inside of the pack so that we can ensure it has been fully sterilized on the inside as well. And as you can see, the steam indicator strip on the inside has turned black, so that is also sterilized all the way through to the inside. Alright, so this is Mr. Kiba. Say hi, Kiba! He just got neutered and had his hind dew claws removed 14 days ago, so he's in for his suture removal. So you can see the healing wound and the sutures right here. There's a little bit of scabbing around the edge, but there's no pocketing, there's no formation of hematomas or seromas, anything that you can see under the skin. It didn't look like it was too inflamed, and there's no bleeding or anything. So we're going to go ahead and take these sutures out. And I've soaked them lightly with some chlorhexidine solution just to kind of soften some of these scabs up a little bit. And then I can get better visualization of these sutures. So it looks like we have about 7 here. And in order to remove these, I'm going to use specialized scissors. These are suture removal scissors. You can see there's a hooked end. It's good for hooking underneath the suture material. So I'm going to visualize the suture line, hook my scissors under, and then I want to pull the shorter end through so that I'm pulling the smallest amount of material through and I'm not reintroducing bacteria into that wound. And I'll move on to the next suture. If it's a little too difficult to remove them with my fingers, I can use some forceps, some thumb forceps, suture removal forceps. You can use hemostats as long as they're specifically designed to remove sutures so that you're not ruining the edge. Okay, and I'm examining the edge of the incision as I go. All of the skin is staying together nicely.
If I tried to pull a suture out and it was tugging and not going anywhere, I would kind of reposition, see what was going on, and try again, so I'm not causing undue pain to Kiba and I'm not re-injuring this suture site. Alright, last one, Kiba. Boop. If there were any large scabs or anything else, I could clean them up, but I'm going to leave this as it is.